laser pointer working?
Yes, sir, we can see.
Okay. Uh, so we'll start this slide seminar. Um, so these are the tumors of the ovary. And can any one of you just tell me why I have highlighted the yellow ones? Maybe Navdeep. So you see a list of ovarian tumors. This is a random table which I put, but I've put something in larger font and I've put something in smaller font and some in yellow highlights. Any idea, Navdeep, why I have put something highlighted, some tumors? Renil?
Sir, it might be the most common tumor that we see.
Most common tumors. So these are the commonest tumors. And why do you want to know about common tumors? Because they are common always. So you understand why I have highlighted and put them in larger font is these epithelial tumors, the germ cell tumors, and the sex cord-stromal tumors of the ovary are the commonest, probably commonest tumors. Obviously, you can have a lot of metastatic, which is also not very uncommon in these tumors. But if you look at primary tumors of the ovary, these are the most common tumors. So even before you put an ovarian tumor on your microscope, you always have in mind, based on certain clinical aspects, the presentation, the age of presentation, maybe the tumor markers, you always have a working diagnosis even before you put the slide on your stage. And that's always important to remember irrespective of what system tumor you're looking at, that always common tumors are common. And if you're trying to make a very rare diagnosis, probably you have to really substantiate your diagnosis in those cases. So in most of these, any system tumors, you would always see common tumors first. And that's why I've highlighted this epithelial, sex cord, and germ cell tumors. So with that prelude, I would start with the case number one. I'm hoping that all of you have seen the three cases. A 59-year-old lady, large solid cystic ovarian mass, uh, or can even come as omental deposits of pelvic mass. Uh, the the performance status is good and there is no lymphadenopathy. Soft pelvic mass is palpable on parabdominal examination, and on PV and PR, the arterial fornices are full and there is a 15 to 15 centimeter palatable mass which they can seen in the. So what investigations would you think when you have a large solid cystic ovarian mass or a pelvic mass in a female? So let me tell you very clearly, in a 59, 60 or a sixth and seventh decade female, any pelvic mass, sort of unless proven otherwise, is generally an ovarian mass. So that's the first clinical point we would need to keep in mind. Even before you look at the serum tumor markers, investigations, or anything, you have a working thought process based on the clinical presentation that a pelvic mass in an elderly 60, 70-year-old female is likely to be an ovarian mass. So these are the investigations. Can any one of you, maybe Adiba, can you tell us about something about tumor markers? So in this patient, the tumor marker CA125 was very high, 2372.
Yes,
So
sir.
okay, so what is the importance of CA125, CEA, and CA 19.9? Can you tell me, Adiba, what is important and why it is important? Any random, just speak up. Just tell me what you think. Is this raised CA125 equal or equated to ovarian cancer?
Yes, sir. Please check the levels of CA125 for serous tumors of ovary.
Okay, only serous tumors of ovary. Anybody else? Fiosha? Fiosha, you want to tell us the importance of serum tumor markers like CA125, CA, and CA 19.9? Is Fiosha still there? Hello? Hello? I don't think they are
Sir.
able to hear. I'm not very sure whether. Fiosha, you're able to hear me?
Yes, sir.
Yeah. So what is the importance of these three tumor markers?
For ovarian tumors.
Okay, ovarian tumors you mean to say. So supposing CEA was 2000 here, would it be still an ovarian tumor or not an ovarian tumor? CA 19.9. So we will start discussing just to keep the things going. So this patient had a large complex solid cystic mass and the tumor markers were elevated. Now I want to tell you here that CA125 will be raised in epithelial ovarian tumors, but it may not be raised to this extent. Then it may sometimes be only 100, 120, it may be 80, 85. So CA125 raised is not equal to ovarian tumors. It is a marker of irritant of the peritoneum. So when you have a lot of peritoneal deposits and a lot of tumor in the peritoneum momentum, your CA125 generally goes up. So even in a GI tumor, sometimes you may get mildly raised CA125, and it basically tells you that this is something which is not always equated to an ovarian epithelial neoplasm. But having said that, most of the ovarian neoplasms would have a raised CA125. The more important usage of CA125 is in the follow-up of these patients. When these patients are treated, ovarian cancer patients are treated with chemotherapy and surgery. When they're being followed up, then that's when the rising CA125 levels might be more helpful to pick up a recurrence in these patients. So that's the importance of CA125. If you look at CA and CA 19.9, 19.9 is a generally supposed to be pancreatobiliary markers. But mind you, in certain ovarian tumors like a mucinous tumor, CA 19.9 point can be very, very high. CA can also be raised in other tumors like metastatic ovarian tumors, Kuchenberg tumors may have CA raised, but then the primary is generally in the GI tract. So a CA125, CA and CA199 is a generally a good panel to look at when you are trying to decipher what the ovarian tumor is likely. So if CA and CA19.9 are raised or CA alone is raised, you probably are dealing with a GI metastasis to the ovary. If CA125 alone is raised, then you are probably, sorry, somebody is asking for this. Okay. So CA125 is raised in ovarian, but CA might be raised in GI malignancies. So this is the CT scan of the patient, and you see a large mass in the pelvis, completely filling the pelvis. So when you see this in an elderly woman, you are probably dealing with a ovarian malignancy. Now, can anybody tell what this picture means? Shweta or Ranil? I've just
So,
put this random picture after this CT scan.
yes, sir. So this FNAC picture is showing a cluster of highly atypical malignant cells with irregular nuclear founder and within nucleoli and kind of variable cytoplasm. Sir.
Very good, very good, very good, Mr. Ranil. But did I tell you this is FNAC?
Sir, it's looking like FNAC space. So it's mostly. Uh,
So how do you diagnose? So Joseph says it's atypical glandular cells. Hume says papillary cluster. Why did I put? And it's very good that you called it an FNAC. It actually brings up a good discussion point. I want to tell you then when you have a large ovarian mass, but it is confined to the ovary and there are no omental mets or peritoneal deposits, a clinician will not do an FNAC of the ovary. So FNAC of the ovary is generally contraindicated in a case where the tumor is only confined to the ovary. When you put a needle in the ovary, which is in a tumor which is confined to ovary, you will violate the capsule of the ovary and it upstages the ovarian cancer. You understand? Once the capsule is ruptured or the capsule is violated, then it becomes a T1C stage cancer. So FNAC or a biopsy of ovarian mass is done only when there is generally a widespread disease in the omentum peritoneum. So this is the ascitic fluid. This is not an FNAC. Most people in the audience are saying that this is ascitic fluid, and that's how generally the ovarian cancers are diagnosed. So yes, this is a pap stain smear. This is a papinicolor stain of an ascitic fluid in this patient who had ascites. And then when you do an ascitic tab, you do this cytology, and most of the ovarian cancers are diagnosed by ascitic fluid cytology as initially as metastatic adenocarcinoma. Now, metastatic adenocarcinoma will also be from the GI, can also be from the GI. We don't know. So unless until you make either a cell block or you do a biopsy and do your immunohistochemistry, you cannot confirm a ovarian cancer. So this is the cell block. What do you see in the cell block? This is a HID stain of the cell block. Now, Pete, can you tell me what you are seeing here?
The atypical cell in clusters.
Very good. So there are 3D clusters. Somebody says rosettes. Yeah, generally we don't see rosettes on cell blocks. We don't comment on rosettes, Joseph. Um, these are clusters and they look epithelial. They have some of them have got vacuolations. Navdeep can't unmute herself. She's saying, I don't know why. So there are these clusters of cells with vacuolations. So they look like adenocarcinoma. Uh, so in general, when we look at a cytology fluid cell block, in our day-to-day practice, most of us would end up calling a positive cytology as metastatic adenocarcinoma. Now, when you're looking at fluid, you have to be a little careful. In these cell blocks, you have to look at the age of the patient. Sometimes in a young patients, something which you call as a metastatic adenocarcinoma may actually be a germ cell tumor. So please look at the age of the patient. That's very, very important. Uh, in a young patient, 20-year-old, these cells might represent a yolk sac tumor actually, or an embryonal carcinoma, or even a very bad looking, strange looking or degenerated seminoma. So please look at the age. Just don't blindly call anything adenocarcinoma in a fluid. In a 59-year-old with ovarian neoplasm, definitely you can call this metastatic adenocarcinoma. So what IHCs will you do to confirm the ovarian origin? Anybody? Shweta or Adiba? What IHCs will you do to confirm ovarian origin? Paxate is the Mullerian marker. So first marker is Paxate. That's a Mullerian marker. Obviously, it does come in thyroid and thymic and other and renal neoplasms. Next marker is a P53 and a WT1. So WT1 is marking some of these cells. P53 is very nicely, strongly mutant positive in these tumor cells and Paxate. So this panel is the general panel which you include in a cell block to confirm ovarian serous high grade carcinoma. P53 tells it's high grade, WT1 tells it's serous, and Paxate tells it's a Mullerian origin tumor actually. Now the same patient had mental meds and also they put in a needle and they found that this is the tumor histology. Can anybody describe this histology? Adiba? This is a core biopsy, I think from maybe one of the peritoneal deposit or maybe it's from the ovary itself, adnexal mass. Yeah, it looks like an adnexal mass. How do you describe this?
Sir, we can see tumor cells are arranged in a micropapillary pattern without
Very nice.
fibrovascular
So these
core.
are these floating. So they're not very nice fibrovascular cores. They're just floating papillae here. But even at this power, you can make out that they're not looking very nice. They're looking very atypical. Their nuclei are large, and there is some size shape variation. And then you have the floating papillae. Now, when you have a fluid like this positive, and when you get a biopsy like this, you're almost sure you're dealing with a carcinoma, and you have already done your IHCs on the fluid. You may want to repeat it on the histology sample, and this is a Paxate positive. You can see the nuclear positive, P53 very nicely mutant positive. So this is a high grade serous adenocarcinoma, and WT1 was also positive. So now the question problem always in a serous tumor is about P53. P53 mutant would be seen in high grade. P53 wild type will push you to a low grade serous cancer. Is it important to distinguish low grade and high grade serous? Renil? Or maybe I can ask Fiosha. Yeah, Fiosha. Is it important to distinguish between a low grade serous and a high grade serous? Is Fiosha there? Hello. Or maybe Shweta, can you take this question? Is it important to distinguish between a high grade and low grade serous carcinoma?
Yes, sir.
Why is it important?
Yeah, sir. Treatment wise.
How do they treat low grade and how do they treat high grade? So Tapamita says the treatment varies because the pathogenesis varies. That's very good. So the treatment varies with the fact that high grade are responsive to chemotherapy generally. Okay. So high grade serous cancers are treated with chemotherapy, which is generally paclitaxel and carboplatin. So they would give this platinum treatment and paclicarbo would be given to these patients, and then they would undergo interval debulking surgery after 3 cycles. When it comes to low grade, it's a surgical tumor. So when you give a diagnosis of low grade serous carcinoma, the surgeon will try to remove as much as tumor as possible because they are generally not amenable to chemotherapy. Only 10%, 15% of low grade serous would respond to chemotherapy. Whereas compared to that, a high grade serous would initially respond to chemotherapy. Most of the cases would respond. Some of them might be resistant. And that's why this slide is very important. So when do you call P53 mutant? When you have diffuse strong positive in 75 to 80% of the nuclei. I think WHO mentions 80%. Sometimes we even take 70-75% strong positivity as P53 mutant because of the variability of the fixation and staining and different labs doing different protocols. Complete absence of P53 is also considered as null mutant. So that is also a part of high grade spectrum. So that is so important that you pick up. So sometimes in your cytology fluid cell block as well as in a biopsy, you have WT in packset, but you're struggling with the P53 to call it low grade versus high grade. And when it's null mutant, you have to very carefully look at the background stromal cells. So I just showed you the biopsy here. So you see that some of the stromal cells are also picking up the stain. They're not as strong as this, but they can sometimes pick up these stains. And that would be the internal control sometimes which you look for in these cases. Rarely cytoplasmic diffuse staining is considered P53, very, very rare, less than 5% cases. And when you have patchy nuclear staining, then you call it a wild type staining, and then you think about low grade serous cancer. Agreed? So paxate, WT1, and then P53. P53 wild type will push you toward low grade serous cancer. A P53 mutant, null mutant, diffuse strong staining, diffuse cytoplasmic, will call it a mutant, and you will call it a high grade serous cancer. And the importance is once you call it high grade, they are going to give chemotherapy and then do surgery. Where if you call it low grade, they'll probably try and do an upfront surgery and try to remove as much tumor as possible. So this is a very, very basic ovarian cancer which you are looking at. And if you look at epithelial ovarian cancer, it's not a homogeneous disease. There are so many ovarian. Sometimes you loosely say the patient is a case of ovarian cancer. It does not mean the patient has only one type of epithelial ovarian. There are several different types. High grade serous, low grade serous, different pathogenesis, different treatment protocols, different IHC pattern when it comes to P53. Endometrioid cancer clear cell, they generally arise on a background of endometriosis. So again, their pathogenesis is different, and obviously their IHC pattern and all those are different from the rest of them. Mucinous tumors are completely different ballgame. It's completely different. You can have a primary mucinous ovarian, you have metastasis from different GI tracts. So that becomes a complete. So when you talk of ovarian cancer, ovarian carcinomas, they're basically these five types, and then there are certain other rare like the mesonephric like and all, which I'm not going to. So this is just a picture to show you the ovarian cancers. Endometriotic cyst or the chocolate cyst of ovary, it becomes a very fertile ground to become to develop into atypical endometrium with different mutations. And then there are several mutations like the ARID1A and the P10, which lead to formation of clear cell and endometrioid. When it comes to high-grade serous cancers, we know that around 50-70% of these tumors arise from the fallopian tube now as thick lesions, and then they grow as an ovarian mass. A low-grade serous, on the other hand, goes through a pathway of becoming a borderline tumor and then probably developing into a low-grade serous carcinoma. So when it comes to ovarian serous cancers, there are two main cancers, the low grade, high grade. We have already discussed this. Supposing you are struggling with your P53, please look at the mitotic rate. Generally, in a high grade serous cancer, the mitosis should be more than 12 per 10 hyperfit. So that's another clue. So if you're struggling with your P53 staining and you're not able to make up your mind to call it mutant versus wild type, you should look at the marked atypia of the nuclei and the presence of mitosis more than 12 per 10 hyperfit to call it high-grade serous carcinoma. We have to all agree that at least in our country, 85 to 90% of ovarian cancers present with omental metastasis at presentation. Yes, Dr. Rahul, you are free to, you will get this presentation, don't worry. So this is stage 3 cancer when the tumor involves the omentum. So unfortunately, by the time most serous cancers present, they are already in a non-curative stage when they present. I'll not go into the staging. You can always refer to the staging manuals. But I want to tell you that T3 is the most common stage when we find these ovarian cancers. Okay. So this is the general therapy of high-grade cancers, 3 cycles of platinum and Taxol, followed by interval debulking surgery, and then 3 more cycles of chemotherapy is given to these patients. So this patient got this treatment. These are some pictures, intraoperative pictures which I've put up. You can see how they are removing and mobilizing the omentum, how they are mobilizing the bowel. They would sample whatever tumor they can see after chemotherapy. It is debulk, that's called debulking. It's called interval debulking surgery. So remove as much as microscopic disease they can pull out. And this is the gross of the ovarian tumor. Can anybody describe this gross? Adibi? So this is the ovarian tumor which has come out after your chemotherapy. And this is your grossing, how you would do it. Okay. So you have to take sections from the solid as well as part of the cystic component, the thickened cyst walls. So don't forget to take adequate sections from the solid tuber component. Uh, no, that's not caking, Joseph. Caking is omental cake. That's the primary tumor which I showed you. So these are the sections you would take from the ovarian tumor solid areas. Mind you, many cases which are referred to us, they take blocks from inside the tumor. So you have block from here, block from here, block from here. Many people forget to take blocks from the capsule. I told you once the capsule of the tumor is involved, it becomes violation of the capsule and it's a T1C tumor. Post chemotherapy becomes a YPT1C. So it's very, very important that whatever sections of the tumor you're taking, you take it with the capsule rather than from taking from the internal part of the tumor. That's not necessary. Take the viable part of the tumor along with the capsule of the tumor. That's very, very important when you're crossing the ovarian cancer. So this is what you need to do. General sampling, metrically search for viable tumor. Sometimes only calcification and foamy histocytes would be found, and sometimes you may not find any viable tumor, which is a very, very rare occurrence. Generally, ovarian tumors will respond, but complete disappearance of ovarian tumor is not a common occurrence, at least in what we see. So this is what the histopathology report should include. It should say how much residual viable tumor is this, whether you see it or not, whether it's only in the ovaries, whether it's in the omentum, and you have to say how much tumor is there in the omentum. There is a CR scoring. Many of us do give CR scoring, but at least in our setting, that the clinicians do not very push us to give CR scoring in day-to-day practice. Any questions on this till now? Adiba, Fiyosha, Renil, Navdeep. I think I just wanted to touch upon that almost 50% of serous ovarian cancers may have a BRCA mutation or an HRD repair deficiency mutation in them. And most of the advanced ovarian cancers these days are undergoing BRCA testing as well as HRD score testing. Again, I will not go into the details of that. It's a very complicated thing to discuss here because you are just students and you're learning the basics here. But I just wanted to tell you when the normal uh, uh, BRCA is mutated, when the BRCA is mutated, you can give PARP inhibitor drugs, which we are regularly giving to these patients because PARP is an enzyme which, when BRCA is a DNA binding protein which repairs this DNA damage. When BRCA is mutated, the DNA damage persists. But if you have a PARP enzyme there, that repairs the DNA. But if you give a PARP inhibitors to such patients, then those cells die out. So if you look at this normal cell type, they have got a nice BRCA activity, and if you give drugs, that doesn't affect anything because there is a BRCA activity and the DNA damage is repaired. Whereas in a malignant cell which is harboring a BRCA mutation, where the PARP is active, if you give a PARP inhibitor, that PARP cannot repair the DNA and the cell goes into cell death. So this is the basic understanding behind the PARP inhibition when it comes to ovarian cancer. Any questions on this before we move on to case number 2? Shweta, Renil, Piyosha? Any questions? No questions. Shall we move on to the next case?
Yes, sir.
Okay. So second case is a 18-year-old student who presented with abdominal distension. Ultrasound and MRI revealed a 22 centimeter mass in the pelvis, separate from the ovary, they said, with moderate ascites. Many times the radiologist is not able to say whether it's arising from the ovary, is it fused with the ovary, is it attached to the uterus, and that becomes a problem. Especially when it's a 22 centimeter mass, they would probably never be able to tell it many times clearly whether it's an ovarian mass or not. We are in a session of ovary, so they will take it as an ovarian mass. So, Renil?
Yes, sir.
Yes, previous case was a high-grade tumor. Yes, high-grade tumor. High-grade serous cancer, the previous one. Somebody asking question online. So, Renil, what do you think 18-year-old ovarian mass can be?
Sir, it can be mainly consisting of Dysgerminoma.
Dysgerminoma. So the first
Granulosa
slide which
cell
I showed
tumor,
was,
sir.
sorry, Shweta.
Granulosa cell tumor.
Granulosa cell tumor, 18-year-old. So do you know what are different types of granulosa cell tumor?
Sir,
Adult
juvenile
type
and adult, sir.
Okay, supposing so 18-year-old would have what type of tumor, juvenile or adult?
Sir, juvenile.
Likely juvenile. So that's a possibility. Very good. Renal said it can be dysgerminoma. Renal, can we just call it a germ cell tumor possibility?
Yes, sir.
Yes. So 18-year-old, you have to think three things. Germ cell tumor. You have to think of sex cord tumor like Sertoli Leydig cell tumor. You should think of juvenile granulosa cell tumor. So those are the common clinical ovarian cancers which you see in 18-year-old. Please don't forget that sometimes early rectal cancers can occur in patients as young as 15, and they can metastasize to give rise to Krukenberg's tumor also. Although not very common, supposing this was 25, 28-year-old, you should keep a metastasis from a GI tract also as a differential diagnosis clinically when you looking at this patient. But yes, at 18 year, I think a germ cell tumor is highest on cards, and probably a Sertoli Leydig would be a important thing in this setting. So they did a right salpingoophorectomy, infracolicmentectomy, and retroperitoneal lymph node dissection and peritonectomy. And intraoperatively, the capsule got ruptured. So if the capsule is ruptured, what stage is the ovarian cancer already? So I'll forget about the omentum and RPLD. If the intraoperatively capsule is ruptured, it is T1C. Yes, somebody said it's T1C at least. So this is your tumor. Looks very blue at this low power. It's a little hazy. Sorry for that. So here you can see it's very nicely blue looking tumor. You can see the ovarian capsule is very intact, at least in this section. Intraoperatively it got ruptured, but at least in this section it is very well preserved. Again, very monomorphic looking tumor at this power. And this is a better picture to show you very monomorphic looking tumor. How does the tumor look? Can anybody describe this? Shweta, can you describe this tumor?
So monomorphic type.
Sorry? So
The
Richa says it
tumors.
is non-Hodgkin lymphoma. Very good, Richa. Okay. So before you diagnose, please describe the tumor. It's important to at your stage to describe it. Is there papillary? Is it looking epithelial? Is it sheeting pattern? Is there nested pattern? Is it
The
trabecular,
tumor
cord-like
cells are
pattern?
arranged in diffuse sheets, sir.
Sheets. Okay, very good. So it's diffuse sheet
They
pattern. There
are
are some
monotonous looking round to
very good
polygonal in
monomorphic
monocot.
cells arranged in sheets. Very good. So there are some
Sir,
blood vessels
round
in
to
between,
oval.
but yep, surround to oval. Okay. Now what do you think? Monomorphic cells, round to oval. Is it a round cell tumor? How many of you think it's a round cell tumor? Renal, you think it's a round cell tumor?
Sir, it is large round to polygonal shaped cells, sir.
Okay, okay. Fiosha, what do you think? Fiosha, have you been able to unmute yourself?
Yes, sir.
Okay. Do you see any rosettes?
No, sir.
No. If you look carefully at many things, everything starts looking like rosettes. So don't try to look too carefully. Somebody thinks it's a granulosa. Somebody already said, I think Shweta did say it can be uh, juvenile granulosa, but look at the sheeting pattern. It's completely sheets, and there are some punctated blood vessels in this. And it's a blue-looking tumor. It does give you a feeling of a round cell tumor. Somebody called it's a lymphoma, a non-Hodgkin lymphoma. Does anybody think it's an Ewing sarcoma or a rhabdomyosarcoma? Tapamita says it's immature. So do you think it's an immature teratoma? Is it neuroepithelium?
No.
Yeah, this is better. This picture is better. So is this hyperchromatic nuclei? Is it little vesicular nuclei? Do you see nuclear grooves in this?
Yes,
Coffee
sir.
bean. Somebody says it's a coffee bean appearance. Maybe some small groups of cells here you can make out. Does it look like a lymphoma in this?
No, sir.
No, sir.
Blastemal lymphoma? Is it a blastemal lymphoma? Is it a Burkitt's lymphoma?
No, sir.
No.
Is it Ewing sarcoma? Is it round cell? So see, low power did look like a little onset, but when you look at high power, they are looking more vesicular and more. But does it look high grade or low grade? Let's start looking at it?
Low grade.
So low grade.
Low grade.
Looks low grade. What about these mitosis? You see mitotic count, mitosis here, here. 1, 2,
Yes,
3. I can show you 3 in this field at least.
Yes, sir.
Mitosis is seen. Half of the people in the crowd are saying mitosis is seen. So okay, let's form an impression. So we started by saying this is NHL, non-Hodgkin. Then we moved on to say okay, probably it is not NHL. Most of you agree it is not Ewing sarcoma. Most of you now started thinking because of mitosis we should call it high grade. Does anybody think it is Dysgerminoma now? Or does anybody feel it's a germ cell tumor? Shweta, Navdeep, Renil. Renil, you said Dysgerminoma. Is it a Dysgerminoma?
no, sir, it's not, sir.
Why do you think it's not a Dysgerminoma?
Sir, in this germinoma, there are fibrous bands which contain lymphocytes.
Okay, very nice. Somebody says there is no clearing of cells. The cytoplasm is
Sir,
less.
I
Very
can
good.
see grooving of the nuclei.
You can
Grooving.
see new grooving. So Shweta, I can tell you, I can show you grooving in any tumor. Some tumors, all tumors will have some kind of grooving. But yeah, it's not very prominent grooving. Okay, couple of them. So it is not a germ cell tumor because you don't see very prominent nucleoli. Okay, generally germ cell tumors will have very, very prominent nucleoli. So this tumor was WT1 positive. Now, what do you think? Is it serous carcinoma, WT1 positive? Shweta, you know of tumors which are WT1 positive in the ovary? Richa says it's a DSRCT. So Richa, you did not see any desmoplasia in this at all. Hardly any desmoplasia. But yeah, DSRCT is a good thought, not bad. Because we did think of round cell tumor in this. Swati says she can see call-exner bodies. Now that would be a little more imagination, I think. We really don't see call-exner bodies. Granulosa can be positive for WT1. Very good. So mind you, sex cord-stromal tumors of ovary, especially Sertolis, can be WT1 positive. DSRCTs are WT1 positive. Many gynae tract mesenchymal tumors can be WT1 positive, especially some leiomyomatous tumors can be WT1 positive, especially uterine leiomyomas can be positive. Fibrothecomas, all sex cord can be WT1 nuclear positive. So this is your WT1. It is decently positive, I'll say, in the nucleus. Cyclin D1 we did. We thought maybe it's a high grade ESS, so we did a cyclin D1 is negative. CD10 is negative. Synaptophysin was a little blushy. You may take it or leave it. It's that kind of staining. I thought that there is some blush-like positivity for synaptophysin in this tumor. Does it help? Maybe no. Sometimes granulosa can be positive for this. And then we did a BRG stain. See this? This is called SMARK-A4 or BRG. This is a marker from the Swiss sniff family. And you see these endothelial cells are positive, but the tumor is negative. You agree? All of you agree that the tumor is negative for BRG?
Yes, sir.
Yes,
Okay.
sir.
So whatever nuclear positivity you are seeing either in stromal cells or it's in the endothelial nuclei. The tumor itself is BRG negative. See this? Very nicely, tumor is negative and the endothelial control is positive. More pictures to show you endothelial cell positive. You can see the plasma here in the blood vessel, and you can see that this tumor is negative. Strangely, you can see a conspicuous nucleoli when you do IHC. Sometimes the IHC does bring about a better morphology than HID, and you should always look at morphology sometimes in IHC stain. So this is a small cell carcinoma, hypercalcemic type of the ovary. These are defining IHCs. The loss of BRG1 is sort of defining in these tumors, and they can have a range of morphologies. Now, why I showed you this case, not because it's a rare case, I wanted you to have all this thought process in mind. Somebody said it's a granulosa cell tumor, somebody thought it's a sex cord tumor, somebody thought it's a lymphoma, somebody thought it was a round cell tumor. So that's all the possibilities you have in mind when you have this small cell carcinoma hypercalcemic type tumor. These tumors can look like anything. Generally, they wouldn't have papillary pattern or glandular pattern, but rest of all these pattern like a small cell, round cell tumor pattern, a sex cord-like pattern, a germ cell tumor-like pattern can be seen as these tumors. Please keep this in mind. This tumor is rare, but it is not so rare. You may come across this occasionally. And mind you, if you think that 18-year-old you should do a SAL4, this tumor can be SAL4 positive. Not all of these tumors are SAL4 positive, but a decent number of these tumors would be SAL4 focally positive. So supposing I did a SAL4 in this and few cells were positive in this, I should not jump and call it a germ cell tumor. A germ cell tumor is a curable cancer. It is almost 100% curable in early stages. Even in late stages, those tumors are 70 to 80% amenable to chemotherapy and manageable. Whereas this small cell carcinoma hypercalcemic type, which can look like anything, is generally a killer disease. Most of the patients succumb to their disease within 18 to 24 months. So please keep this in mind. I wanted to show you because I wanted you to give answers and tell us that this looks like so many other tumors can live. So when tomorrow when you look at such a tumor in a young patient, please keep that in a differential diagnosis in your day-to-day practice. It might be a small cell carcinoma. It's a killer disease. It requires very aggressive chemotherapy. It has got poor outcome and is completely different from a germ cell tumor outcomes and treatment in our daily practice. And it can definitely mimic, it can even have SAL4 positivity, which can really make you call and make a wrong diagnosis of germ cell tumor. And that's why I showed you this case. So this is another important time is one third of the patients do not have hypercalcemia. They occur in the reproductive age group. WT1 is generally positive in these tumors. P53 mutations are also common. So you may end up mistakenly call them as serous cancers also. Although generally the tumor does not have papillary and glandular kind of pattern in these tumors. Just to show some differential diagnosis, this is a granulosa cell tumor, a very blue-looking tumor under the microscope. But when you look at hyper, most of the nuclei are very pale. And these have these boat forms and they have these grooves, which you can very easily see in these tumors. But they have the most important feature of granulosa, adult granulosa, is the paleness of the nuclei, which is almost seen in all the cases. Very nice granulosa. Can you see the coffee bean?
Yes, sir.
Yes, sir.
Everybody can appreciate lots and lots of grooves. So this is how the grooves are there in adult granular. Almost like every second, third cell will show you start showing you the coffee bean appearance in a classical case. This is a very classical. And when you do a reticulin, it is around the reticulin fibers are around large nests of these tumor cells, not around individual tumor cells. These are positive for inhibin. This is a picture from juvenile granulosa. Again, a little round and blue looking tumor, but there is a lot of pink cytoplasm. Most of the juvenile granulosa will have these kind of cysts which filled with very mucinous kind of or myxoid kind of material. That's a giveaway and generally a good feature which you pick up in juvenile granulosa cell tumors to pick up. But again, the age is important. Sometimes these granulosa, general granulosa can be very spindly. They can look very pink. They can have a lot of myxoid stroma. They can have these intercommunicating kind of ridges which can be there in juvenile granulosa. It is again the age which is important. You have to look at features, and obviously, when you do your IHCs, you will find your diagnosis. Yes, Adiba, you wanted to say something?
No, sir.
Okay. So our patient's calcium was normal. Patient was given cisplatin, etoposide, then doxorubicin, cyclophosphamide, and finally palliative chemotherapy. She unfortunately succumbed within 1 year of her diagnosis. So this is a very bad and killer disease, and please keep this in mind when you are looking at a young patient with ovarian cancer. So that was the idea of showing you this case. Any questions on this? Renin,
No, sir. Please.
Shweta, Adiba, any questions?
No,
No,
sir.
sir.
No questions. Okay. We'll move on to case number 3. Again, a young patient, unmarried female, 28-year-old. She had a history of fever and her menstrual history was okay, I think, pretty much okay. She had on per abdominal examination 18 weeks kind of abdominal pelvic mass. Uh, and cervix and vagina were healthy and cervix was normal. Abdominal pelvic mass was felt separate from the uterus. So again, we are dealing with an ovarian tumor, possibly ovarian tumor with a 28-year-old tube. So again, what are the differential diagnosis? Renin, Fiosha,
Teratoma.
Teratoma.
Yes, sir. Immature teratoma.
why somebody is calling it choriocarcinoma? How common is choriocarcinoma of the ovary? Not common. Not common, no? So this is ultrasound showing a large solid cystic abdominopelvic mass. You can see that the septa can be seen very nicely in this scan. CA125 was 160. The LDH was 3000. So what does LDH signify? Anything? Any significance to LDH? AFP was 85. Beta HCG was normal. Somebody said choriocarcinoma. So choriocarcinoma is out with this beta HCG, almost out with this beta HCG. It will almost never be 1.2, okay? And the choriocarcinoma. But AFP is mildly raised. LDH is markedly raised. So Joseph says it's a yolk sac tumor. CA125 raised. Is it ovarian serous carcinoma? Shweta?
No, sir.
No, sir.
No. So these are MRI pictures again to show you this ovarian mass in the pelvis. Very nice. 20 centimeter mass. Large complex polycystic mass. You can see the septae and you can see this part of the cyst of this ovary. These were the perioperative findings. It's an old case. So frozen section. Should you do a frozen section in these cases? 28-year-old female. Maybe just to discuss frozen section. Anybody can pitch in, please. Shweta, Renil, Adiba. When do you do frozen sections for ovary? Rachita says yes, you would do frozen section. Apurva says yes, you should do frozen section. So one of the very strong indication to do frozen section for ovary is in young patient. Okay, you're trying to preserve her fertility. Whenever you have a, say, supposing in a 28-year-old, I call it a high-grade serous on frozen section, the management and the treatment for high-grade serous to do a THBSO. So no 28-year-old and no family of a 28-year-old would want her to lose her uterus. You understand? The whole idea of doing frozen section in young patients will preserve her fertility. It may turn out to be endometriotic cyst. You understand? In a 28-year-old, there is a possibility that it may turn out to be benign. It may be borderline tumor. It may be cystadenoma. So if it is a benign tumor at frozen section, they will not do anything else. They will just remove the cyst. If it's a borderline, they will do salpingo-oophorectomy on the same side. They will not do anything else. But supposing at frozen section, you tell the surgeon, intraoperative, that's a high-grade serous carcinoma, it's a high-grade endometrioid carcinoma, or it's a high-grade sex cord-stromal tumor, something, they would have to remove her uterus intraoperatively. So please be very, very careful of looking at frozen section of ovaries because you are in a unique position to preserve the fertility of that patient. If you are
So,
in doubt, yes, please.
sorry, did I interrupt, Dr. Santosh?
Hi, Jai Madam.
Hello.
Jai Madam, please,
Yeah,
please, please join in.
no, I just wanted to say that, because this was an 18-year-old, so,
No, it's
even
28.
the
She's 28-year-old.
surgeons,
This is 28
this is
year
a
old.
28-year-old, sorry. No, because if she's nulliparous, then, the basic dictum even for the surgeons is only based on frozen section. I don't know how much would they consent to do a
So I think,
THBSO,
Chair,
especially
if
if
I
it is
remember,
a ovary
we have
confined disease.
exactly.
So, we would think, of course, we would take cues from there, but especially if it is a very young patient, and many a times, they do consent that because maybe, on the frozen, I don't know how sure you can be. So, if it is, of course,
So I think, Jai
35-year-old
Madam, it has
lady who has
happened
completed
maybe.
her family,
Yes,
so there, you would take the decision based on a frozen. But for a
exactly.
20-year-old, 25-year-old, taking a decision, nulliparous lady taking a decision only on frozen can be, very, very catchy. And most
Yes,
surgeons
exactly.
and least they do not, because, we've had young patients, something looks like high grade on frozen and then it comes back as a borderline. I don't know whether they can or cannot look
Not too
alike.
many cases.
Then,
I think in my remembrance, I think I have had couple of patients where it was very outright high grade serous. It was not a 28-year-old, obviously, it was a 32-year-old. But again, like you said, the patient had completed family, and so they went ahead and did a complete total resection.
yes,
But it's in only
but
a
when,
very, very minority of those cases. But my point of showing this is that frozen section in an ovarian mass in a young is almost done routinely in day-to-day practice from a pathologist point of view
Mhm.
and a
Because we
clinician's
have to
point
be
of view.
very, very careful because sometimes, somebody may undergo a THPSO just based on that
Exactly. So
report.
nobody. So we are
So,
extremely careful to call something high-grade malignant tumor in ovarian frozen at frozen section. If we are in doubt, we would definitely not overcall in these cases. So that's very, very important, and that's what I am trying to tell you in this this case. So this was on final. This was an 18 centimeter tumor of the ovary. No capsular breach was seen. There was a solid cystic cut surface, and 5 sections were taken at initial grossing from the solid areas. Can anybody describe this? Shweta, can you see what is this section from the ovarian tumor?
Sir, section shows multiple cystic structure.
Very good.
Sir, lined by
Line by?
columnar.
This is not column.
Columnar.
No, this is not column. This is columnar maybe here, a little bit. Somebody thinks it's Brenner. This is keratin here. I'll move
So
on to next one.
keratin is present within the follicles.
Very good. What about this one? Somebody said squamous cell with keratin. What is this? Blue.
I see a histology slide microscope, and it looks like bolts.
It's a cartilage. Yes. Yeah. It does look like cartilage. Very nice. So there is cartilage, there is chondroid material, and then you have this immature neuroepithelium. You see this very beautiful immature neuroepithelium. We'll go to the higher power to see this. So this is how immature neuroepithelium can look like. You can have these very blastemal looking blue areas. The central part of this area is generally little necrotic and little breakdown in the central part of this area. You can also have immature neuroepithelium with multi-stratification, and you can have this kind of arrangement of the luminal border of these cells. That's how immature neuroepithelium looks. So at low power, it can look very glandular kind of appearance, but when you look carefully, these are very blastemal looking elements which you see, say, in a neuroblastoma or a nephroblastoma kind of appearance which you see in these tumors. So this was called as immature teratoma grade 1. Are you happy with this report? Piyosha, are you happy with this report of immature teratoma grade 1? How big was this tumor, Shweta? 18 centimeter. How many sections did you take?
5.
Are you happy with this
5.
number of sections? Adiba, are you happy with the number of
No,
sections taken at gross?
No, sir.
No, sir.
Everybody agrees?
Yes,
18
sir.
centimeter tumor, how many sections should you take? It is generally one section per centimeter, okay? It is generally, the dictum is to take 1 section per centimeter. And because you took less number of sections, somebody called it an immature teratoma grade 1. So you are not happy with this answer. For 18 centimeter, only 5 sections were not adequate. There is no description of capsular involvement, and grade 1 immature teratoma will be given no chemotherapy. So you have to understand that when you call something grade 2, grade 3 immature teratoma, the chances of that patient giving chemotherapy is very high. So if it is grade 2, grade 3, and Jaya madam, you can correct me. But if it is grade 2, there is always a question, should we give chemotherapy or not? A grade 3 immature teratoma will be definitely given chemotherapy. So the point of interest and point to be noted here, an 18 centimeter tumor, which is a germ cell tumor, where you're seeing some kind of immature neuroepithelium, don't jump and call it unless you have taken more sections. The most important take-home message is, in an immature teratoma where you are calling it grade 1 or where you're seeing very little neuroepithelium, please go and take adequate sections, at least 1 per centimeter of the tumor. That completely can change the management of this patient. So you have to take adequate more sections. You have to look at the capsular involvement, which will change the stage of the tumor. And you take more sections to look at other germ cell elements. So AFP was 70, 80 in this patients. Maybe when you take more sections, you might find yolk sac component. Sometimes even in immature teratoma, the AFP is raised mildly in these tumors. So this is the grading of immature teratoma taken from the WHO book. So when you look at immature neuroepithelium, you have to look at the aggregates of immature neuroepithelium. If any one slide has less than 1 focus, 4x focus, you call it grade 1. If any one slide of the sections you have taken has more than 4x focus of immature neuroepithelium, then it becomes grade 3. So you see how it is so much dependent on the number of sections which you imagine, which you take at gross. So the adequate grossing is very, very important in these tumors. Many times we get only 2 blocks from a teratoma slide from outside in a 20 centimeter tumor, and we are seeing some focus of neuroepithelium. We should not be grading on that very suboptimal material. Unless until, of course, it's a straightforward grade 3 immature teratoma. Jaya madam, any
So,
comments on this?
no, I have maybe mainly question on this. This has been a perennial doubt is that say you have 18 sections of this patient and one slide shows whatever one immature 140x
4x.
magnification.
Yeah.
Huh?
4x is our eyepiece. Yeah.
Yeah, so this is what in 4x magnification
Objective,
or
sorry. Objective.
sorry?
4x. So 4 into 10. Eyepiece is 10 and 4 is your objective. So any 40x, that's the magnification which we are looking at. If any
Yeah,
one
so any
slide out of this
40x.
18, any one slide of this 18 has more than 4x focus of immature neuroepithelium, I would call it grade 3. So you have to look at every slide. Actually, you have to look at every slide. You have to aggregate them together also. So supposing you have, I don't have a diagram, but if you have a slide where there are tumor foci, small tumor focus, you have to mentally put them aggregated into 4x focus. If it is more than 4x focus, in one slide it becomes grade 2. If it is more than 4x focus in any one slide, it becomes grade 3. So that's how you remember it. It's a very strange kind of a system, but it has stuck
No,
around
so
because it's been there for.
the question is like if I have 3 or 4 slides, each having one focus,
No,
then will it be grade 1?
no,
Like
no.
like you
Yes, it will still be grade 1. If there are 4 slides, each having very small focus, it doesn't become grade 3.
okay.
It has to be in any
So
one
any
slide.
one slide which is so if you have in one slide you have 4 focus and another all the others have 1, so it will become grade 3. Is that correct?
Yes, 4 focus which are more than 4x fields. So 4 more than 4x fields. 40x fields. Total magnification. So maybe I should have drawn a diagram to show this, but this is extremely confusing for many people. Some people want to add up all the slides and call it grade 3, but any one slide, please keep in mind, any one slide, if it has got more than 4x focus of immature neuroepithelium. We have seen immature neuroepithelium in our presentation here. This is how immature neuroepithelium looks like. This is how immature neuroepithelium looks like. So this is like 4x focus. Everything coming in 4x focus will become grade 1. If it is more than 4x focus, then it becomes grade 2. If there are
Where is the
more than
immature
3,
neuroepithelial?
this
You
one,
have
this one,
multiple
this
areas,
one,
no?
this one, multiple area,
So
but
you
this
have
all
1
will
and
come
2
in
and 3.
4x field. This will all come in 4x field. This
So
will
it's
all come
grade
in
3.
4x field. As long as it is accommodated within 4x field, it will grade 1. That is what this means. Understood? Any questions? Navdeep, you were saying
Yes,
something?
sir. No, sir, understood.
Joseph is asking if 4 low fields in 5 slides, one each in no. So you have to take in any one slide, Joseph. Any one of the slides, you have aggregated neuroepithelium more than 3 fields, then it becomes great. So this is an older version. I'll not get to go into the details, treatment details. I think this is from a clinical scenario. Now we have another similar. Yes, I will explain it once more. Let me finish my presentation. We'll deal with this. This is confusing. You'll have to go back to your book and actually try and learn how to do this. So another similar case is 26-year-old female, again a dysgerminomatous germ cell tumor with immature teratoma grade 2 and yolk sac tumor. She was only operated outside TMH and no chemotherapy was given, and now she presented with a retroperitoneal mass with elevated tumor markers AFP and beta HCG. So treatment was now given with chemotherapy. She was given chemotherapy. After chemotherapy, her tumor markers were normal. The patient defaulted for 1 year. So that means the patient did not follow up. And again, she came back with a CT scan evidence of residual growing mass in the retroperitoneum, but markers were normal, completely normal markers. See, the first recurrence, she had raised AFP and beta HCG. So there was some other germ cell tumor. So what are the possible diagnoses when you have normal markers but a growing mass in a germ cell tumor? So these are the possibilities you need to keep in mind. It can be a growing teratoma. It can be an immature teratoma or embryonal carcinoma where the markers may not be raised, and other thing is a somatic malignancy arising in germ cell tumor. So what do you mean by growing teratoma? You may still have teratomatous tumor which are growing and the markers would generally be normal in them. You won't have raised markers in this tumor. You may have immature teratoma with embryonal or embryonal carcinoma. Again, the markers may not be raised in them. Sometimes immature teratoma may have raised AFP and embryonal carcinoma may have raised beta HCG levels. But again, these are the possible pathologies where markers may not be raised in a recurrent tumor setting. Again, somatic malignancy like a squamous carcinoma, adenocarcinoma, or say a rhabdomyosarcoma arising in a background of germ cell tumor, the serum tumor markers would be normal. So this you need to keep in mind when you're dealing with a germ cell tumor case. A germ cell tumor which comes back without raised AFP, raised beta HCG is likely to have some of these pathologies. Obviously, if it's just post chemotherapy, it may just be necrosis or some post chemotherapy changes in those retropetal masses. But generally, if you have retropetal mass which is growing but the markers are normal, you should keep these three differential diagnoses in your mind in day-to-day practice. I think I'll just skip these ones. These are uncommon ones. These are the common germ cell tumors: Dysgerminoma, immature teratoma, yolk sac tumor. Very rarely in compared to the testis in the ovary, embryonal carcinoma, choriocarcinoma, these are very rarely seen in the ovary. This is the age group where you see 14 to 45 years. This is the age group of germ cell tumor. And generally, the investigations are ultrasound, CT, abdomen, pelvis, MRI. Very, very important tumor markers. Never forget in a young patient ovarian mass, you have to do AFP, LDH, and beta HCG. AFP and beta HCG are more important in these cases. LDH has become more or less non-specific in such a setting. Generally, LDH is raised in pure Dysgerminomas, but any tumor which has got very high turnover will have high LDH levels in this. So the take home message is GCTs, germ cell tumors are rare. Age and serum tumor markers are important. Very, very important. Don't forget serum tumor markers. When you looked at the first case of serous ovarian cancer, there we looked at CA125, CE, and CA19.9. When the age is 14-45, young patient, you have to do AFP, beta HCG, and LDH in these patients. Adequate sections at gross are very important. Stage is important. And prognosis is excellent even in high stage disease in germ cell tumors. These are some of my acknowledgements, some of the cases. This is an old presentation. I had taken help from Dr. Shalini from AIMS Rishikesh, and these are all my colleagues and friends from whom I learn in day-to-day practice. Thank you so much for your patient listening, and we can take up some questions now. Jaya madam, thank you for joining.
Yeah,
Any
sorry. I
questions?
think, you kind of specified. So I just want to make one more point is that even for a germ cell tumor, you can have raised CA125. So,
Yes.
CA125 may be 5,000. So that does
Yes.
not make it an epithelial ovarian cancer for a 25-year-old, irrespective of the CA125. Please do an AFP beta HCG LDH.
Yes.
So, that
So
as
we
a
had discussed
bottom
that in
line.
the first case. We had a serious high grade, and I told them CA125 is pretty non-specific, and sometimes it may be raised in other tumors.
Yeah, and also I think I don't know, initial slide I missed. One of the other very great mimickers are your clear cell and your yolk sac tumors. So
Yeah.
I think they are very lookalikes. And many times if
Yes.
we get a young patient with a clear cell carcinoma, they turn out to be, uh, yolk sac tumors. So that is the other thing.
Yes.
And the prognosis for two are like 180 degrees opposite to each other. So
Yes.
that's another
Yes.
thing
Yes.
you can
Completely
mind.
opposite. Yolk sac tumors now. Any questions?
Sir, there are a few questions.
Somebody is moving the screen, is it?
Yeah. What if
To
BRG is not available in small cell carcinoma hypercalcemic type? How do we diagnose?
So small cell carcinoma, I think the most important thing, Vanessa, is to keep be aware of the presence of this tumor. And like I said, if you don't think of it, you would probably do a SAL4. Mind you, SAL4 generally should be diffuse in a germ cell tumor. Very focal positivity, with like which you see in a small cell carcinoma case, it's generally not a diffuse SAL4 positivity. That should raise the red flag that this is not a germ cell tumor. And synaptophysin is generally positive in these small cell hypercalcemia. WT1 is generally positive. A1, A3 or keratin is very focally and dot-like positive in these tumors. Generally, other neuroendocrine markers would not be that great positive. So I think the morphology, the high grade appearance of the tumor, WT1 positive, cyanotophysin, SAL4. These are some clues to point to that this is a small cell hypercalcemic type. And
Yeah,
if you have
And
just a
hypercalcemia,
point
all the
that,
more.
the initial treatment for both of them will be cisplatin etoposide. So,
Yeah.
the clinical person can start the treatment and send for BRG, whatever verification, so that, we can eventually prognosticate them. But our initial plan of management will be cisplatin etoposide, but of course with very, very widely different prognosis. So if we are suspecting that, I think we start, and we don't have that facility, we can start treatment and, send that markers. I mean, if that answers your question. Yeah.
Paxate positive, generally small cell is not Paxate positive. P53 can be mutated, Aisha. Somebody says, Jaya madam, your voice is very sweet. So Jaya madam, you can continue.
Oh no, I didn't know. I can't see chat for some reason. So
No, I'm
thank you.
seeing the chat.
and in most of the
Somebody has asked,
cases,
can we tell
small cell
immature neural element in frozen section? If there is a lot of immature element, we can definitely pick in a frozen section. If there is very focal immature element, it can be very difficult. You may not be very confident of calling something immature neuroepithelium at frozen if the section is not good or if the immature element is very less. But if you have a lot of immature element and it's got the typical morphology, I can in frozen section you can definitely call it a. Mansi is asking, is LDH is very non-specific. Can it be increased in Warburg effect? So generally, Warburg effect causes lactacidosis, if I'm not mistaken, Jaya madam. Warburg tumor effect is when the tumor grows large, it becomes, it uses the
anaerobic
anaerobic glycolysis pathways, and I think
glycolysis.
lactic acidosis is the common thing which occurs in those patients.
So I
Yeah,
think
please.
bottom line is that LDH is high in any high grade tumor. So
Yes.
any high grade tumor, be it a Burkitt, be it a, of course it is a marker for Dysgerminoma. But that way it's a little non-specific, and any high grade tumor, like something like even in an Ewing's and LDH is high, or say for that matter, even an RMS, they're a kind of prognostic markers where we look at tumor burden. So I think it's a
Yes.
more of a marker of
High
any
tumor
high
turnover.
grade.
Yeah,
Hmm.
that's what we generally tell. It's a high tumor turnover marker. Any tumor which is turning over very or undergoing depth and growth together will have high LDH. How many bits to be taken on frozen section to differentiate borderline versus carcinoma? See, there is no cutoff for doing frozen section. You cannot take 20 sections at frozen section. Please understand that a borderline tumor is predominantly a cystic tumor with focal papillary excrescences. We did not touch upon that. We did not have a case to discuss today on borderline tumors. It's a complete chapter and a complete presentation in itself, and I didn't want to confuse you with that. But borderline tumor generally seen in younger patients, generally large cystic masses with papillary excrescences focally. And when you take sections, at frozen section, you take 2, 3 sections from the papillary areas, and you would be able to look at the hierarchical branching, and you would be able to call it a borderline tumor in most of the cases.
So I think, from my side, it will be that if in doubt, say that you're in doubt and, leave it at that. Because I think you can take the patient would
Yes,
undergo a unilateral salpingo-oophorectomy, you'll get
exactly.
the whole specimen, and then you can take many
Of
more
course.
sections and
So,
decide,
so the
because
idea
that
of
would
frozen
change somebody's
section,
life. Hmm.
every time frozen section, if you are in doubt, you should not overcall frozen section. That is the general dictum in most cases of not overcalling and not overdoing the surgery at frozen section.
So there's one doubt. Can immature teratoma post-surgery grade 1 from an anterior abdominal mass?
Uh, See, immature teratoma is a malignant tumor, any malignant tumor, but generally a grade 1 teratoma would not come back unless until there has been violation of the capsule and there has been if somebody has used a port site and then some port site deposit has come up. So like I said, if you have a grade 1 teratoma coming back as an abdominal mass, probably yeah, there has been some violation of the capsule completely gone. So last month we had one case of a mature teratoma. It was almost completely mature except for very little immature element. We couldn't even call it a grade 1 immature. but there was intraoperative capsular rupture, and the whole mature teratoma came back within few months as multiple deposits in the abdomen and abdomen wall. So these are all generally malignant tumors. So they are sort of yeah, they can.
Yeah, and it's, I think, from of course, most of them are pathologists from a surgical perspective. These large tumors, they need an open surgery.
Yes.
Laparoscopic morcellation is the, something which is a very kind of spreads the tumor. You have port site mets, you have all problems. So I think these are young patients. So, that is why the thing on getting those out through some smaller holes. But I think what is most important, if you have 15-20 centimeter tumors, those patients should undergo an open proper laparotomy and surgery, so that even if it is borderline or a mucinous carcinoma or a low grade carcinoma, these patients can be spared so chemotherapy for these patients, and they will not come back. They will have very good outcomes. Whereas if you morcellate the tumor, break it into pieces, then they kind of spread in the whole abdomen, and you get things like port site metastasis. So that's
Yes. Somebody has asked, can we accept an ovarian mass of around 10 centimeter in frozen section? So mind you, most of the mucinous ovarian tumors are 20 centimeter, 30 centimeter, 35 centimeter tumors. So there is no size criteria to accept a specimen in frozen section. You are not going to put 30 centimeter in frozen section. You are going to take 4-5 section in large, even in large tumors. Generally, you would cut the tumor, look at more solid areas, and take sections from solid areas at frozen section in the ovarian mass. That's a general dictum what we follow. So there is no size cutoff of accepting specimen in frozen section. Yes, Yosha, you want to add something?
One practical
Yes.
question. This small cell carcinoma of the ovary,
Mhm.
usually only after we get the slide, we have the doubt of it. So by the time the calcium levels will be normal. So only the
So calcium, yeah, calcium may be normal, calcium may still be raised. It's not like that if there is some small metastasis somewhere, the calcium may be raised. Most of the cases which we have seen, Dr. Jaya, I think we have found calcium to be pretty much normal in these cases.
Sorry, as Madam rightly mentioned that, many times if we get it post surgery and it was an early stage disease, we don't get high calcium.
Yeah,
And correct me, Dr. Santosh, that, some of these patients even otherwise may not have high calcium.
No,
So it's
no,
only
it's
patient-wise with very large, high burden of disease. They are the
yes,
ones who present with hypercalcemia. So if hypercalcemia is present, it is a very confirming factor. But if it is not present, we cannot say it is not just because it is
yes,
we
yes,
don't
right.
have high calcium
I
levels.
think that
So
name is stuck. Maybe over the years, it might change into some BRG deficient tumor of ovary. That's a possibility when the next classification and all come up. So there is a move to sort of have all these sniff tumors as a family of tumors. Maybe that's a possibility. So such terminologies like hypercalcemic type and all may confuse people a lot. So I think we need to have a more unified classification terminology. But it's again a
yeah, but
terminology. It doesn't
definitely.
change the tumor.
Yeah, but definitely we do check for serum calcium whenever you raise that suspicion. So that is there.
So I think we are done. Wonderful.
yes, sir. So it
Any
was an
more
awesome
questions?
talk. No more questions, sir. It was an awesome talk.
Purva is still there. I don't know Purva is there.
Yes, sir.
Purva is there. Yeah. Any questions from you, Apurva?
Really enlightening lecture, sir. I've been attending.
The
No, I
cases were
don't have.
very simple. The cases were very high grade serous cancer, one hypercalcemic tumor, and one germ cell. So I tried to cover up. My borderline was difficult to cover. It's a complete talk in itself. Maybe sometime later we can have a talk on maybe mucinous tumors and all these borderline tumors. Dr. Gujral is traveling somewhere. Time for him to go out and have his coffee.
Yes,
Borderline is
thank you
very
very much,
difficult.
Santosh. I think excellent jugalbandi between you and Jaya. So Sheetal and I have been enjoying. We're driving actually, as you guessed, to a coffee shop. We just parked on the corner to say thanks to both of you. Thank
Dr.
you very
Jayan's
much.
Jugalbandi is there for 17-18 years. Jaya, बहुत साल हो गए.
Yeah, thank you. And I think these are the cases that we day to day have problems with. So, I always tell my residents that don't just read from a clinical perspective, we tell to read the whole report which the pathology person has written, and then, so that we can go back and ask them report, and also to know the clinical context. Because if my clinical context is not fitting with the pathology, always go back to the pathology and ask, and vice versa. So as a pathologist, I think you should also look at the history, the clinical context, and see if, things are matching. If they are not, then you, of course, kind of check back again. So look
Yes.
at
So we
tumor
at
markers,
Gen-
look at CT scans. I mean, even like I think the joint clinic is useful because seeing calcification on the scan where you're suspecting a teratoma, and you can see, the radiologist can tell you that, you see nice, happy teeth all over the place, and, so those kind of things. So I think a joint clinic thing wherever feasible would be useful, and at least make an attempt to go through their history and the radiology findings as well. So that's my take home. Thank you.
yes.
Any final comments, Santosh?
I have done. It's always enjoyable to have questions and answers. And
Any final comment from you, Jaya? Jaya, you want to say anything?
Yeah, no, sir. I just said that. Thank you so much. Thanks a lot, sir.
okay,
Yeah, I
thanks to
also
the
learned each time.
moderators. I think Vanessa and Apurva, thank you for your moderation. And
Yeah,
if there are any
thank you,
more
sir.
questions,
Okay. Thank you.
thank you so much.
Thank you, sir.
Thank you.
Thank you.